Auzubillahiminashaitanirrajim. Bismillahirrahmanirrahim. Okay, guys, let's start today's session with this bird. This, what do we call this? Flamingo is staring at you through your soul and asking you to study in this session. Okay, guys, let's start. So, today we are going to do the guidelines of intrauterine fetal death. So, let's just start. The thing is that no signs of life. Okay, no signs of life after the you can't understand what I'm writing. You just have to listen to me. I'm writing just for the sake of writing. I know it's not understandable, so just listen to me, okay? No signs of life from the age of viability that is taken as 24 weeks in guidelines, okay? And when does this happen? If this situation, that is no signs of life after 24 weeks, happens in utero, then this is defined as late intrauterine fetal death. I don't know what is early intrauterine fetal death. It has not been mentioned in this guideline. They have just labeled this as late intrauterine fetal death. And if this situation happens after birth, not intrapartum, not during delivery, after birth, then this is known as stillbirth. Like right after the woman has delivered, you check there are no the signs of life. They also include, they don't just include heartbeat and crying, they also include umbilical cord pulsations, things like that also. So if they are absent after delivery, then that is called as stillbirth. But if they're absent when the baby is still inside the uterus, in utero, then that is known as late intrauterine fetal death. So I hope now you know the difference between these two terminologies, because I didn't know that. I honestly didn't know that. Okay. So this is the definition of late intrauterine fetal death. So let's just understand the algorithm. First of all, I would advise you to study the algorithm for reduced fetal movement. There's a discussion that I have uploaded. Please watch that, because the woman is not going to come to you and say, I think the baby is dead. No, God forbid. She's not going to tell you that. She's going to come up with decreased fetal movements, or she's going to come up with no movement, or maybe she's going to come up for a regular antenatal checkup and you are going to see that there are no hearts on just a regular antenatal scan. And maybe she might present with DIC if it's a lot of days have passed, because what is the risk of DIC after intrauterine fetal death? At least try to guess what percentage. So it is 10% within the first 4 weeks, of intrauterine fetal death, late intrauterine fetal death, and then it increases thereafter, okay? I used to think that maybe it will increase progressively every 48 hours, because in my mind, the intrauterine fetal death, next thing was the risk of DIC. But this is the stat, okay? 10% within the first 4 weeks of this incident, and then it increases thereafter, okay? So please remember this percentage. It's very, very important for your exam. I need another page. This habit of wasting pages in diaries is a very bad habit, but we all have bad habits, so it's okay. Okay, now, I don't know how you have diagnosed it. Let's say that she presented you with reduced fetal movement and whatever, but now you think that this is an intrauterine fetal death. How are you going to confirm the diagnosis? Like, what is the method of diagnosis? Are you going to use a CTG probe? Are you going to diagnose simply? You don't have time. There are a lot of patients who just you're going to use your Pinard fetoscope, or are you going to do a proper real-time ultrasound? So this is common sense that it's not a joke. So you're going to do a proper real-time ultrasound to check the fetal hearts, and then you are going to seek a second opinion. Okay, this is very important. And then you are going to declare it or diagnose it. But you have done all this, and now the patient is saying that she's still having fetal movements. Fetal movements are there. Now what are you going to do? You're going to tell her, you're going to counsel her, option A, or you're going to dismiss her because she's just, in shock right now, or you are going to do an ultrasound again. Why would you do an ultrasound again? I mean, I don't think this is the answer, okay? Or you are going to just, okay, these are the three options. Can't think of any other option. So you have done the real time ultrasound, you have sought a second opinion, and this is how you diagnose it. You have diagnosed it, you have declared it, you have counseled the family, but now the woman is saying that, doctor, I'm still having fetal movements. What is going on? So what are you going to do? You're going to counsel her? No, you're wrong. Absolutely. You are going to do another ultrasound. This is the algorithm. So at this point, you are doing a third ultrasound, but you're going to do it because the Green Top guideline asks you to do it. So you have to do it. Okay. So you are going, because now you know that you have diagnosed it, right? You have also sought a second opinion. So now you have confirmed that this is an IUFD. Why is the patient having fetal movements? Do you know the answer? Because these are passive fetal movements, okay? They can be happening because of uterine shuffling, maybe because of some twitching, or maybe because of, especially probably because of the movement of fluid around the baby. So I have seen two patients up till now who were having an IUFD that was found incidentally on scan, because according to them their fetal movement was perfectly fine. Okay, so fetal movement is a subjective thing. You can rely on it, but it's also very scary. I mean, fetal movement really scares me because you don't know what the patient is perceiving. Okay, so you're not involved in that, so it's kind of, it really scares me. Okay, so these are actually passive fetal movements which are happening. So in this case, you know that these are passive and you know why they're happening, but instead of counseling, the guideline asks you, doesn't ask you, it orders you to repeat ultrasound. Okay, so now we know how we're going to diagnose it, the whole thing. And if she complains of fetal movements, we know why are they happening, and we know that what are we going to do. Okay, another ultrasound, right? So after this, the patient is, everything has happened, declaration has been done. Now she is saying, please, doctor, do a cesarean right now. Okay. And I'm doing these are SBAs that I'm discussing, okay? I'm not just randomly making up questions. These are SB and EMQ points, so please listen to me, okay? So she's saying that, doctor, please do a C-section. I can't bear with this anymore. Just take this out. I don't want to experience labor pains. Right now, do a cesarean, doctor. What are you gonna do? Of course, you're gonna listen to the patient. You can't go against her wishes, so you're gonna prepare the OT, the OR. You are going to counsel her again. You are going to induce her anyway, counsel her and induce her right away. What are you gonna do? You're going to counsel her because right now she is in shock. Give her some time, okay? Usually within 48 hours, labor pains, they come on their own. And the perception that you cannot wait is wrong. You can wait. Now the patient has two choices, okay? After counseling, she's probably fine now. Either you're going to induce her, do an IOL right away, or you're going to wait. So it depends on, if there are no sign. Wait, the diary is falling off. The diary is very non-cooperative. Let me just fix it. Okay. Please someone buy me a tripod stand. Okay. So there are no signs and symptoms of DIC. Okay, then you can wait. If there are signs and symptoms of DIC, you have to expedite it right away. It's a danger situation. But if everything is fine, you can wait. You can wait for 24 hours, you can wait for 48 hours, you can wait for even longer. But you have to induce her eventually if she doesn't spontaneously go into labor. So you have these two options: IOL, wait, and if there is DIC, then expedite right away. So let's say that now you're going to IOL. How are you going to induce her in this case? So you can go for meso, followed first you're going to prepare her with mifepristone, with or without mifepristone. Then you're gonna go for with meso. You can use an intracervical Foley's catheter. You can also augment her with Synto during labor. But this augmentation with Synto during labor must be done on consultant's advice. This is what the guidelines है. खुद से नहीं शुरू हो जाना कि आप फर्स्ट ईयर सेकेंड या थर्ड ईयर ट्रेनिंग या ट्रेनिंग आप कह रहे हो Synto चला दो. Guidelines आपको मना करती हैं. Okay, don't do this. This Synto should be used after consultant's advice. Okay, so now we're gonna go back to ये देखिए writing कितनी neat हो गई. I can do a good handwriting, guys. Okay, so yeah, so there is a 10% chance of maternal DIC within 4 weeks of intrauterine fetal death. ये बात हम अब already discuss कर चुके हैं. सब कुछ ठीक है तो crazy नहीं हो जाना कि ओहो DIC अभी deliver कराओ. You can wait, okay? Unless there is signs and symptoms, there are signs and symptoms of DIC, then you have to expedite right away. So if you are going for induction labor, within 24 hours of induction, vaginal births occur in 90% women, okay? 90% of women with IUD, they deliver within 24 hours of induction. So first line is mifepristone plus a prostaglandin, okay? So 200 mg mifepristone you're going to give it. And then you start giving prostaglandin, you're going to give meso. So depends on the gestational age. So if she is 28 weeks and onwards, then you can either go for a dose of 25 to 50 microgram per vaginally every 4 hours, or you can double the dose, that is 50 to 100 orally, but now you have to also increase the duration interval every 2 hours. Okay, which one is better? Vaginal, the benefit of vaginal is that there are no adverse meso symptoms. With meso you can have diarrhea and flushing and stuff like that, so you're not gonna have it if you're using it vaginally. So, and you need a lesser dose, so I think vaginally is better according to the guidelines. Okay, now let's go back. Now if she is on 24 to 24 plus 6 units, says 4 and 4, so the dose has to be 4. The dose is also 400 microgram every 3 hourly, and then from 25 to 27 plus 6, the dose is 200 microgram half, and every 4 hourly. Okay, so you just have to memorize this. Let's just go through this again. From 24 to 24 plus 6 weeks, what is the dose? It's written, you just have to read it. Please read it out. It's 400 micrograms every 3 hourly. And then from 25 to 27 plus 6 weeks, it is 300. It's 200 micrograms every 4 hourly. Okay, 400 micrograms every 3 hourly and 200 micrograms every 4 hourly. Okay, next we have discussed 28 weeks onwards. Okay, so this is very simple, right? But things are not this simple. What if she has a previous one scar? You want to go for a VBAC. What are you going to do? In this case, you can also induce, but there is the window for induction is smaller. What is the window for induction? Please, guys, a random guess. I have already marked it. Yes, you cannot induce a previous one scar beyond 27 plus 6 weeks, the red window. So the induction can be done from 13 to 27 plus 6 weeks. I don't know why have they mentioned 13. 13 is not the age of viability. This is not included in the definition of IUD. The definition starts from 24 weeks, but still they have mentioned. In none guidelines